Fundus findings for the general ophthalmologist will be presented by Dr. SAMEERA. She is consultant vitreoretinal surgeon at Sampatha VR Specialty Center, Tirur, Malappuram.
Good morning, everyone. Fundus findings for the general ophthalmologist. It's a very vast topic. I don't know how am I going to give justice by giving an 8-minute talk. All right. So I'll be just brushing with the common things which are going to see in our normal practice. So you might be very much aware, I think so, like this is the story of an elephant with 6 blind men, where everyone perceived differently once they touch the elephant. So is the case with retina, like when you perceive what you see is not, and the perception is entirely different. So once you have a structured examination of the retina with the evaluation of the disc, then the posterior pole, and then going to the mid periphery and the periphery, you can at least arrive at a conclusion like what it is. So I'll be just brushing with only the common things what you see. So the disc, the unilateral disc edema, this is the most common thing which we come across. Okay, so the disc edema, like it can be unilateral or bilateral, but the unilateral you can actually, differentiate whether it is AAON, as you can see here, which you have a segmental pallor, and you can actually, depending upon the age, you can differentiate, whether it is a papillitis or AAON. Bilateral disc edema, once you see multiple cotton wool spots and a disc edema, this will be more favoring of malignant hypertension. If it is not there, it can be a raised ICT or a space-occupying lesion or a trauma. Bilateral disc edema, the differentials can be bilateral AON, it can be diabetic papillopathy, as you can see the telangiectatic vessels on the disc. Bilateral papillitis is also not so uncommon. Pseudopapilledema can be seen. So this all can be differentiated with the help of the history, the visual loss and associated other symptoms, and the signs like color vision and the pupils. Neuroretinitis presents with disc edema, with other triad being the optic disc swelling, as I've told, and the visual loss and the macular star. Now, retrobulbar neuritis, the patient sees nothing and the doctor sees nothing. You can go for the VEP. Now, physiological cupping, as you all know, it is a horizontally oval disc which is respecting the Essen rule. Once this is not done, and when there is an asymmetric cupping of more than 0.2, you can suspect it's a case of glaucoma. Myelinated nerve fibers, don't just brush this off. There are so many systemic and ocular associations associated with. So you can go ahead and find out like something is there or not. Now, this is an interesting case where you can see in the first picture, it's a case of optic disc coloboma. What about the second one? So that's a 6-year-old child who's presenting with history of trauma. So the picture is similar, but that's a case of optic nerve avulsion. Now, pale disc, it's so common these days because of the augmented dosage of ethambutol toxicity. So even though you don't see the pallor initially, but when you are suspicious, don't hesitate to go for a VEP. This is associated, pale disc is associated with vascular occlusions, nutritional is not that uncommon, and trauma is another cause. So this is a very interesting case. As you can see over here, it's a 10-year-old girl, and it's a case of optic disc hypoplasia. Now coming to the posterior pole. So diabetic macular edema, it can be either center involving like what you see over here, or it can be a non-center involving edema. So depending upon the edema and depending upon the visual acuity and depending upon the symptoms and signs of the patient, accordingly you can treat it with either with anti-VEGF injections or a non-center involving edema you can observe, or you can go for a focal laser. Now, what about this? Hard exudate plaque. Don't just hesitate that the patient is not going to improve. The patient is very much under control with the diabetes. And when you start giving statins, you can see like how beautifully the hard exudate plaques are melting. And at the end of 1 year, the patient has improved from CF2 meter to vision 636. Now, asymptomatic, totally asymptomatic patients like this, when you present, so this is a typical case of high-risk AMD with confluent multiple drusen. So you should always look for any subtle SRF or IRF. So baseline OCT is needed for such kind of patients. Now geographic atrophy, it's a case of an advanced ARMD. This is with so much of structural loss. Now, you see so many conditions like this also with a fibrotic scar. Even if the vision is so less, still you can actually look for that whether there is so much of SRF or IRF, you can actually treat to salvage the existing vision, at least the CF1 meter can improve to 4 to 5 meter as well. Now, the importance of the other eye in such cases are, you can see a very thin grayish membrane if you can visualize. So you should never miss the other eye of such patients because this is a PCV which is sitting in the good eye. Now, this has been referred from elsewhere as a case of impending CRVO, but in the inferior part, you can see a large subretinal fluid which is sitting over here, and this has ended up with PCV again. Now, myopic CNVM, it's not only the lattice degeneration which you have to look for. Closely, always under high magnification, look for the center of the macula, because 5 to 10% of eyes with high myopia can go for a myopic CNVM. You can see the subtle bleeding points, a very small subtle bleeding tinge if you are viewing the patient like every 6 months to 1 year, or a small SRF. Always see that myopic CNVM is not missed. Now, this is a typical case of hemorrhagic PED with other hemorrhages and all. So this is a good hemorrhagic PED, but this is a PCV, and post Eylea injection, the patient has beautifully improved to 6/9. Now, sudden loss of vision during dialysis, case of hemi-CRVO, when the visual loss is out of proportion to what you see this whitening of the retina. This is actually, it's a combined occlusion. So you can treat this as CRVO, but this should not be missed. Now, chronic CRVO, you will be seeing it regularly, and always look for signs of ischemia. Look for NV and NVD whenever you see the patient on every single visit, and look for NVI, and gonioscopy has to be routinely done. Now, you can see the NVD in this case. Now, nasal BRVOs, if at all these are asymptomatic also, don't just leave the patient. Keep following up the patient because they can end up with a vitreous hemorrhage later. So, ischemia has to be looked out. Now, cherry red spot. Cherry trees never grow tall in sand and mud. So, as you all know this norms. And this is another patient. You can see the whiteness over there at the posterior pole. Don't just think that it is just a fibrotic scar. Basically, it is a small retinal artery occlusion sitting over there. So the visual was totally disproportionate to what you see over there. CSR, mostly it is like the blurring or distortion. Mostly we tend to miss at the initial stages and all. So, but in elderly, when you see such cases and all, rule out underlying neovascular causes. Now, this was referred as a case of a CSR, but this turned out to be serous PED. Now, full thickness macular hole, this can be, correlated with either it's a macular pucker or a lamellar hole. So, lamellar holes, you can wait, but full thickness macular hole, always you have to refer for a VR surgeon. Now, Stargardt's disease, in the due course of time, you can see this has ruptured and finally it has ended up with a scar. Retinitis pigmentosa can be sectoral or the full-blown retinitis pigmentosa. You have to correct the refractive error to the maximum, and the central part of the patient is having a visual loss. Look for cataract, ERM or cystoid macular edema, which can be treated at the correct point of time so that the existing vision can be salvaged. Juxtafoveal tail-length rickettsia, most of the time this has been missed in our day-to-day practice. So such cases when the vision is not proportional to what you see, always look for the high magnification time. You go for their blended right angle venules or superficial retinal crystals, is there or not. Toxoplasmosis, you can see fresh cases like this with vasculitis, or it can be seen adjacent to a scar. Whenever you see a macular toxoplasmosis, it is always better to go with intravitreal clindamycin. It works wonders rather than giving the oral antitoxoplasmic agents. So this can be associated with a secondary CNVM later. Sarcoidosis can be associated with anterior uveitis. You can see snowballs, vasculitis, choroidal nodules also can be seen, so treat accordingly. Blunt trauma, even if you see the blunt trauma patients and all, please follow up these patients. You can see the different types of traumatic maculopathy, choroidal rupture and all, and this has to be documented also in our current scenario, which is this can go for litigations later. Now, white dwarf syndromes, it's not that so uncommon. Now, peripheral retinal degenerations like lattice degeneration, this is actually, it's a Garrett atrophy, but you can see the cobblestone, which is in the center picture, and snail tracks also, and operculated hole. The holes has to be treated as soon as possible, but lattice with suspicious hole, always you can go for a regular checkup. Thank you. So this is in a nutshell. Thank you.